A 40-year-old man was taken to the emergency department by his wife, complaining of lockjaw. The patient was restless, irritable, and was sweating profusely. The wife also complained that the patient was having difficulty in swallowing while taking meals. On further questioning, the patient revealed a history of stepping on a rusty nail while he was working in the garden a few days ago. On examination, the patient had neck stiffness and rigidity of the abdominal muscles. A bedside spatula test was performed, which made the patient bite down on the spatula rather than gagging. Complete blood count and lumbar puncture results were unremarkable. Based on the findings in history and examination, a clinical diagnosis of tetanus was made. Tetanus is a life-threatening bacterial infection caused by the bacterium Clostridium tetani. In this video, you will learn the etiology and pathogenesis of tetanus, its 4 clinical types, clinical presentation, prognosis, diagnosis, and treatment of tetanus. This video is made with reliable sources of medical information recommended for medical undergraduates and doctors, and the references are mentioned at the end of this video. You can also download questions, flashcards, and notes related to this video for free from my Google Drive. The link is given in the description below. I highly recommend you watch the video till the end, and if you think that this video is worth your time, please hit the like button, subscribe to the channel, and share this video with your colleagues. So, without further delay, let's get into the business. Tetanus is characterized by acute onset of hypotonia, painful muscular contractions, typically in the muscles of the jaw and neck, and generalized muscle spasms. Although individuals of any age can be affected, elderly people are more susceptible to getting the infection. First, let's discuss the etiology and pathogenesis of tetanus. Clostridium tetani is a non-capsulate, obligatory anaerobic, motile, gram-positive bacillus. It forms spores that are resistant to heat, disinfectants, and desiccation. Under proper anaerobic conditions, these spores germinate and produce 2 types of toxins: tetanolysin, a type of hemolysin with no pathologic activity, and tetanospasmin, which is responsible for the clinical manifestations of tetanus. It is one of the most potent toxins known, with a minimum lethal dose of 2.5 nanograms per kilogram body weight of a human. Tetanospasmin consists of a heavy chain and a light chain. The heavy chain mediates the binding of tetanospasmin to the presynaptic motor neuron, and it creates a pore for the light chain to enter to the cytoplasm of the neuron. Once the light chain enters the motor neuron, it travels by retrograde axonal transport to the spinal cord and acts on the central inhibitory neurons. The light chain is a zinc-dependent protease that cleaves a transmembrane protein called synaptobrevin in the central inhibitory neurons. Synaptobrevin is essential for fusion of the neurotransmitter-containing vesicles with the cell membrane. Cleavage of synaptobrevin prevents the fusion of GABA-containing vesicles with the cell membrane, causing loss of central inhibitory action on motor and autonomic neurons. This will ultimately lead to autonomic hyperactivity and uncontrolled muscle spasm in response to normal stimuli. It is important to note that once the toxin becomes fixed to the neurons, it cannot be neutralized with the antitoxin. So, the recovery of nerve function requires sprouting of new nerve terminals and formation of new synapses. The infection commonly occurs due to wound contamination with bacteria or spores. Examples include acute wounds such as puncture injuries, lacerations, abrasions, and burns. Chronic wounds, including diabetic ulcers and venous ulcers. Childbirth is also a significant risk factor for tetanus, especially in developing countries. Other instances where contamination can occur include the following: intravenous drug abuse, intramuscular injections, tattooing, frostbites, dental infections such as periodontal abscesses, dental procedures such as root canal therapy and tooth extractions, and umbilical stump infections in the neonate. In addition, comorbid conditions like diabetes and under-immunization increase the risk of getting tetanus. Now let's discuss the clinical presentation of tetanus. As mentioned at the beginning of this video, tetanus can be divided into 4 different clinical types: generalized tetanus, localized tetanus, cephalic tetanus, and neonatal tetanus. Out of these 4, generalized tetanus is the commonest type. The average incubation period in generalized tetanus is about 8 days, which largely depends on the distance between the toxin inoculation site and the spinal cord. Lockjaw, also known as trismus, is the first presenting symptom in about 75% cases. Other early features include muscle rigidity, headache, seizures, irritability, restlessness, profuse sweating, also known as diaphoresis, dysphagia due to pharyngeal muscle spasm, drooling, and spasms of the back muscles. Over time, muscle rigidity and spasm become the major manifestations of tetanus. Rigidity spreads in a descending pattern from the jaw and facial muscles to the extensor muscles of the limbs. Reflex spasms occur in most patients and can be triggered by minimal external stimuli such as noise, light, or touch. They become more intense and frequent with disease progression, and sustained spasms can result in apnea, fractures, dislocations, and rhabdomyolysis. The early manifestations of tetanus indicate the involvement of bulbar and paraspinal muscles, presumably because of their shorter axons. Urinary retention is also another autonomic symptom seen in generalized tetanus. Sustained trismus gives a characteristic facial appearance called rhizus sardonicus. Persistent spasm of the back muscles cause opisthotonus. Neck stiffness is also commonly observed in generalized tetanus. On some occasions, patients may have abdominal tenderness and guarding, mimicking acute abdomen. Autonomic involvement causes arrhythmias and fluctuation of blood pressure between hypertension and hypotension. Localized tetanus typically involves an extremity with a contaminated wound. The severity of this type is highly variable. In mild cases, there is weakness of the involved extremity, and in severe cases, intense, painful spasms occur in the group of muscles near the site of the injury. Localized tetanus is usually self-limiting, but severe cases may progress into generalized tetanus. Cephalic tetanus usually follows head injury or middle ear infection. It is characterized by variable cranial nerve palsies, especially of the facial nerve. Neck stiffness may also be seen, and some patients may present with features of generalized tetanus. Neonatal tetanus is a form of generalized tetanus that occurs in neonates. It is commonly seen in developing countries, and the usual cause is the use of contaminated equipment to sever or dress the umbilical cord in the newborns of unvaccinated mothers. Newborns typically present with inability to suck, poor feeding, and excessive crying. Physical examination findings are similar to generalized tetanus. Apart from these signs and symptoms, tetanus can cause a wide range of complications, including the following. Spasms of the vocal cords and respiratory muscles can lead to breathing difficulties, which may result in asphyxia. In the past, the major cause of death from tetanus was asphyxia. However, with the advent of neuromuscular blockers, mechanical ventilation, and control of spasms with medications, sudden cardiac death has become the leading cause of death due to tetanus. Cardiovascular complications include arrhythmias and pulmonary embolism. Because of the respiratory and cardiovascular complications, many patients with tetanus require ICU care. During hospital stay, they can get complications such as bed sores, sepsis, hospital-acquired pneumonia, aspiration pneumonia, and catheter-related infections. Other possible complications include long bone fractures, glenohumeral and temporomandibular joint dislocations, urinary retention, paralytic ileus, malnutrition, stress ulcers, coma, and flexion contractions. The diagnosis of tetanus is based on the history and physical examination findings. Tetanus should be suspected in any patient presenting with sudden onset muscle stiffness and spasms, especially if they have risk factors for the disease. No specific lab test is available for the diagnosis of tetanus. Full blood count and other blood chemical findings are normal unless they suffer from another pathology other than tetanus. Wound cultures become positive only in about 30% of patients. Lumbar puncture may be helpful in excluding other causes responsible for the neurological findings, such as meningitis and encephalitis. In any case of suspected tetanus, a spatula test can be performed. It is a simple bedside test that involves touching the oropharynx with a spatula. Under normal circumstances, it elicits a gag reflex, where the patient tries to expel the spatula from the mouth. However, in tetanus, patient develops a reflex spasm that causes the patient to bite down on the spatula, as you can see in this picture. Finally, let's discuss the treatment of tetanus. To bind and neutralize the circulating tetanus toxin, human tetanus immunoglobulin should be administered. It is important to note that these immunoglobulins cannot neutralize the toxin that has already been bound to nerve endings. Wound debridement should be started after administration of immunoglobulin because of the possibility of releasing further toxins into the blood. Patients should be kept in a quiet, dark environment to prevent reflex spasms. In severe cases, ICU admission should be considered. Some patients may even need intubation and mechanical ventilation, as well as neuromuscular blocker therapy. Maintenance of optimal nutrition is also extremely important during the hospital stay. To eliminate the bacteria from the site of contamination, metronidazole is used as the first-line agent. Alternatives include clindamycin, erythromycin, tetracycline, and vancomycin. Benzodiazepines, especially diazepam, are used to prevent muscle spasm, relax muscles, reduce anxiety, and produce sedation. Other than diazepam, lorazepam, midazolam, vecuronium, and pancuronium can be used for this purpose. If spasms are not controlled with benzodiazepines, long-term neuromuscular blockade may be needed. Other agents used for muscle spasms include baclofen, dantrolene, short-acting barbiturates, and chlorpromazine. As the specific therapy for managing autonomic system complications and spasms, magnesium sulfate is recommended. However, it is important to monitor for signs of magnesium sulfate toxicity. Beta blockers are also recommended, but they increase the risk of sudden cardiac death. For hypotension, fluid replacement with or without dopamine or norepinephrine may be needed. Sustained bradycardia may warrant the insertion of a pacemaker.